the pregnancy, during pregnancy is really a marvelous stress test for the whole life of a woman. If you fail, if you have hypertension or diabetes or even preeclampsia, you have a lifetime increased risk of cardiovascular event. And therefore, a lot of younger women have their OB/GYN as their family physician, and oftentimes when they go through this complications of pregnancy, they may not remember the details. They just know that they need to have some medication for the sugar, for the blood pressure, and maybe the baby was born earlier than intended, and the baby may be lighter, and you need to get those histories from the women, because oftentimes they don't, the OB/GYNs may not refer those patients to you for a cardiovascular follow-up. And as you can see, the risk of cardiovascular disease in women, at the bottom it includes history of preeclampsia, gestational diabetes, and hypertension. So stress test for life is this pregnancy. It could be because women who have this pregnancy-related complication already have a baseline cardiovascular or metabolic problem. The pregnancy just unmasks the underlying issue. Or the pregnancy itself, because the hormone is different, it triggers or damages the vascular endothelium. So we don't know which is which, but those women have a higher event. So you need to ask the woman how many pregnancies and miscarriages is important too, especially if it's after hypertension. That means that the glucose or blood pressure is bad enough to affect the baby's health. If you have protein in your urine, preeclampsia, how many weeks they have to deliver your baby early? Is that because you're sick or because just you want to fit into your schedule? The weight of the baby. So the hypertension, these are just a definition of the hypertension during the pregnancy is gestational hypertension. If you have hypertension before the pregnancy, it's chronic hypertension, just different definition. Hypertension during pregnancy happens in 6 to 8% of the women. It increased once you have hypertension during pregnancy, you have increased chance of future hypertension, ischemic heart disease, stroke, thromboembolic event, heart failure, arrhythmia. Scary. And all of these curve just by a glance, it's bad. It's all going up. This is just the definition of hypertension. If the pressure is higher than 140/90, or more than 300 milligram of protein in a 24 hours urine, if it happened after 20 weeks of gestation, and that's called hypertensive disease related to pregnancy. And they also have very similar pathway compared to older women with atherosclerotic disease. Preeclampsia, recurrent eclampsia, and these are just observational data that more than 2 million women are observed for 13 to 15 years. They increased future metabolic syndrome, obesity. Their rate of cardiovascular event is similar to women who smoke. And these are the relative risk factor. And the degree. I know I'm running out of time. So preeclampsia, once women have preeclampsia, look at how high the cardiovascular event is in their lifetime. And these are just data showing that when you already have hypertension, even in the future, your diabetes rate and death rate is higher. And that shows that perhaps women with hypertension during pregnancy have the abnormal metabolic mechanism behind this hypertension, not just the volume increase with pregnancy. And preeclampsia is also called maternal placenta symptom because the symptom abated after the delivery of the placenta. And they have a higher rate of hospitalization, atrial arrhythmia, but not significantly higher ventricular arrhythmia. Women with preeclampsia and fetal growth retardation or even death have an even higher future event rate for their lifetime. And these women tend to have higher glucose, develop insulin resistant, higher triglyceride, higher LDL. So once they have a pregnancy complication, including preeclampsia, sugar, and blood pressure issue, you need to follow up them closely for lifetime, even though they are still premenopausal. Pregnancy already stratified, failed pregnancy as a stress test already stratified them into a higher risk group. So in summary, I know I'm running out of time. These data are very useful, at least to me personally, when 20 years ago, my mother called me and told me that my grandmother broke her hip, and my grandmother was always very healthy, fit person, and after breaking her hip, everything go downhill, and my mother was very afraid, and she was 5 years after menopause. She said, I already suffered through, when I mentioned that she lives in Hong Kong, so I mentioned that she needs to take hormone to protect her bone, and she said, well, it's already 5 years beyond, I already suffered through the hell. Why should I start? And it's harder to convince a woman who don't have any symptom, or anybody who have no symptom and take a medication to prevent something down the road. But, so I told her that the nurse health study, and she started the hormone. And later, when I was a fellow in late 90s, there are data showing that the HERS trial may not show that the hormone may be bad for women, so I said, Mom, stop. So, so she used the hormone for about 5 years. I was still not sure if I stopped the hormone too prematurely because she still is a tiny woman. When you're light, your bone is not really carrying so much weight on a daily basis, so you don't really have the stimulation of building the bone every day. Every day you lose some bone, build some new bones. So if you're really light, you have a much higher chance of losing more bone than building compared to heavier women. So my mother is still tiny, so I kept thinking that if I had stopped the hormone too prematurely. But now with more data showing that, okay, at least we know it's safe to use hormone in younger women before they are 10 years after menopause, and it's safe to use for maybe 5 years, shorter period of time, but after that it's no good. So at least I feel better that I did the right thing. But still, right now we still don't know for a young woman like me what to do. 39, I had ovarian cancer, so surgical menopause was something I faced at 39, and the symptom was terrible. It was easy for me to, before that, it was easy for me to say to a woman, oh, hormone's bad for you, just tough it out. But it's so hard. So I took the hormone myself because I couldn't live without it. And I kept thinking, am I harming myself? But gradually I studied the data more carefully. I know, oh well, I'm younger, so perhaps in the women health study, those younger women who are surgically menopause, I think they were after 20 years of follow-up, they're still good. So I know at least perhaps in 20 years I'm still okay, but at that time I should stop. But at least I feel that I'm not harming myself by taking the medication to feel better today. I'm not killing myself for tomorrow. So I think it's something very important for us to we are all probably the source of health information for our families and friends, and they may not have the OBGYN or family practice physician who are very up to date. They know the guideline, but it's not enough when you know yay or nay, black and white in the guideline. You need to know the gradation, and that's why we want to know these 3 important landmark trials, like you know some famous inventor in medical history. Thank you.